Good evening, friends. Welcome you to the evening Tuesday sessions of Critical Care and Emergency Medicine from Yashoda Group of Organization. We have been doing this for the last year and so, and we have an interesting case today. A patient who actually presented to us around a week and a half back with a similar pandemic peak with a obesity of around 140 to 150 kilo. With a hospital stay of 4-5 days in another hospital and shifted to our hospital in an ambulance with an NIV support. And once this patient reached to us with a NIV on and FiO2 almost to reach of 100% and saturating hardly between 40 to 60%. This was a nightmare which anybody of us can think about in all our COVID patients. The situation at that time was also been grimms. Now it is easing out. So how did we manage this case? A patient who reached us in that state with such a moribundly obesity, a team of critical care clinicians who are jump onto these patients to save this patient. How did we could actually bring his life back to normal? That's the story of today. And we will also go through a stepwise approach to this case. How did we intubate it? What was the challenge in intubating this case? How did we manage the oxygenation during this intubation? What happened immediately post intubation? How difficult it was to ventilate this case? And this patient was hardly saturating above 40 for almost a period of an hour or so. And then what was our next call of proning this patient? What challenges we came across during the proning? And how did we could actually bring this patient back from this ventilation? This is the whole story of today's talk, and we have Dr. Sai Sundeep, who is a fellow in critical care medicine from Yashoda Secunderabad Hospital. He will bring this case to us, and probably we will interact in between, and we will also invite questions from the all audience. Over to you, Dr. Sai Sundeep.
Thank you very much, sir, and good evening, everyone. So in the last about 3 to 4 months, we are seeing a huge spike of COVID cases. So this is one case what we have managed and brought him out, as sir has spoken about. So he's a 44-year-old male patient. He's a 44-year-old obese patient who was about weighing about 140 to 150 kgs, roughly with a BMI about greater than 40. So he has about on and off fever for the last 10 days and on and off cough with occasional expectation since the last 5 days. And the day he presented to us, there was a rapid progression of shortness of breath, almost roughly about grade 4 MMRC. So he was managed outside, but because he was worsening, he was shifted to our center. So the outside report says that his CT severity was about 15/25 and his RT-PCR is positive outside. So because of the pandemic and rapid progression of disease pressing into the second week of illness, this was the preliminary data. And the moment we received him, he was conscious, but he was not able to talk in sentences. And he was very much tachypneic also, and he was breathing at about 35 to 40. He was literally in gasping with use of all accessory muscles. And though he was given an NRBM trial, he was not working out. So we put him on NIV of maximum support of 1 FiO2. And in spite of this, he was hardly maintaining between 75 to 80% and sometimes hardly 85. So the ABG was showing only a PF ratio of 50. So this particular scenario, because of the second week of illness and severe shortness of breath, rapid progression, and all these, we have some preliminary diagnosis. The initial was because of a PF ratio less than 50, extensive disease is severe ARDS, what we thought of. Other is cytokine storm, particularly because he had one fever spike, and because he's much obese, any obstructive airway disease, and add on to these three events is a morbid obesity, are the preliminary add-on information we have. So this is the ABG on the first effect, where it shows only a PO2 of 50%. So this is the initial, which is a very low value of 100% FiO2 of being given to the patient. So because he was not maintaining with maximum NIV support, and there is always a high chance of impending respiratory arrest as he was not maintaining, we have decided to intubate him. So what challenges we expected and how did we proceed are the things. So first thing what we expected, because as we discussed with the senior faculty members, the chief of the critical care team is with us, and one of the senior consultant was with us. So we anticipated, because he's obese, difficult airway is the first problem what we thought, and which is very alarming. And next thing, because he was not oxygenating well, we are also worried about the hypoxemic events. And because he's a COVID patient, we need to give full dose of paralytics, short acting agent, which might further decompensate the respiratory failure, is the further event. So because all these are the events which we anticipated, and we made certain things in ready to deal with the things. So, but though this case has actually come up with worsening hypoxemia, he was only hardly PF of 50. The usual way of intubating in COVID patients depends on 4 parameters. So SpO2, general sense, that is GCS, and FiO2, and work of breathing. In this particular patient, SpO2 is almost very low. He was requiring 100 of FiO2, that is 1, and he was very much tachypneic and in respiratory distress. So we didn't wait and thought of going for intubation. So which is almost a very intubation, suspecting impending failure. And the thought of prolonged NIV didn't work for him, though he was very short time. Usually because he was not maintaining, it doesn't work in this patient, because his work of breathing is also very high. So this is a general way how we have prepared for this patient. 2 issues what we thought is, first, he is COVID patient. Second thing, he is morbid obese. So the safety of the patient and the physicians or the nurses which are available, and what preliminary steps. So because he's positive, everyone was wearing a full set of PP with the respirators and their head shields. We avoided all sorts of aerosol procedures like using HME filters during NIV and during bag and mask ventilation. We used both viral filters as well as HME filters during the procedure. And so this is our setup, what we have in our place. So the senior faculty member is at the head end to intubate, with one of us at the head end, and one loaded with the trunks and one with the airway cart, crash cart. And with the assistant help, the chief was also with us. So the pre-oxygenation was again a problem in this patient, because we have given NIV and he was not maintaining on NIV. So we need to shift him to bag and mask ventilate, that is to pre-oxygenate him. And regularly the method of C and E technique, what is happening is there is a significant amount of leak which might be a probable cause of aerosol. So the V and E technique, that is both your fingers will be on the mask of the patient and which is pressing, and similarly with the 3 fingers putting on the angle of mandible and pulling it upwards. So this is a technique what we have raised our ventilation strategies. So once we have pre-oxygenated him, we have given a full dose of paralytic agents. What we have used is rocuronium, and the different crash cart instruments what we have is, first is a different types of tubes rising from 7.5, if required 6.5 to 8.5. This is the McCoy blade, which is used in difficult airway, a video laryngoscope, and the same time 2 different sets of laryngoscope. This is a disposable kit, which is particularly we are using right now in COVID, with the 2nd generation LMA, the other accessories like the Bain circuit, the syringes, the ties, all this. But these 4 are some of the crucial instruments, and we have also given a call to our fellow colleagues for bronchoscopic guided intubation if required, and it is on standby. So this is at the time of intubation. We have, because almost 3 to 4 senior fellows are available. So a huge lot of people, though we thought to avoid because it's a difficult case, we took the help of each and every one we could get off. So this is the general algorithm in obese patients. So always anticipate difficult airway, make your difficult crash cart ready with you, and use of NIV, that too with the help of filters. It has to be a rapid sequence intubation. And if you are pre-oxygenating, if required, semi-sitting position, particularly not to have an effect on your airway. So this is a preliminary area. So what has happened is, as he was not maintaining on NIV, we've shifted to bag and mask ventilation. But the moment everything was ready for intubation, the sedative was given, the paralytic was given. The moment paralytic was given, patient saturation started to drop to 60%. So there was a very huge amount of difficulty in ventilating the patient. We almost 3 persons, 1 person holding the mask and 1 person bagging. In spite of doing this, also he was not ventilating. So we immediately intubated him. The moment we intubated, the tube has gone in the first attempt with all the emergency on standby, but luckily it has gone in the first attempt. But after tubing, whatever his saturation is hardly 40. So we have connected to him at a volume control ventilation initially with the regular setting of 6 ml of tidal volume, IE ratio of 1:1.5 and rate of 24. And initially we tried to give a PEEP of 6, but subsequently, because the volumes what we are getting are not much decent value, so we started to recruit the patient. So subsequently we started a PEEP of 40 for about 40 seconds, and we have optimized taking the complaints in the volumes what is generated. And
Sandeep, for a second. See,
yes.
I think the many of the times in our medical school days in post graduation, we learn many things like this difficult airway crash cards and difficult airway algorithms and all. But when you come across the practical situations like this, where in spite of your all the ideal equipments around, seniors around, and you give a relaxant and you able to ventilate. In fact, we are able to ventilating this patient, but we are not able to oxygenate him. His saturations were hardly going up beyond 60 in spite of all the maneuvers, including an airway with a fitted mask. There is a good chest rise. Everything is happening because there is an issue with oxygenation, that is probably alveolar gas exchange, which is not happening at the membrane level. So we are not able to retain the saturations with all our efforts. And this was almost continuing almost for a hour or so after even intubation, in spite of all those regular standard ARDS ventilation which we come across in our regular teaching. We upgraded our P, we tried to use IE ratio, we tried to do all the maneuvers, but initially for almost an hour or so, we hardly could get a saturations above 60. Always it was between 40 to 50 with all our maneuvers, whatever we could do during a regular standard ARDS. Then we started recruiting, and with recruitment also, it took a long time for us to get a saturation somewhere between 60 to 70, and then slowly it started touching 80. And believe me, we started with the PEEP of around 24 to 26 initially, and it took me for an hour or so standing there at the bedside, optimizing the PEEP, and somewhere we able to optimize somewhere around 18, where the tidal volume was stabilized, my oxygenation was stabilized somewhere between 80 or above, which I have to accept in this case. So what I'm trying to focus here is, in spite of being your standard protocol of difficult airway, in spite of you following a standard ventilatory management, what we generally do in a normal situation, these cases who has a very poor oxygenation, your pre-oxygenation doesn't work, you will not have any reserve, they desaturate rapidly, they crash rapidly, and they also are going through a very heavy cytokine storm in them. And in spite of you being intubating also, you take a long time to actually recruit them. But looking at this time, if you ask me honestly, at a point where I was seeing a saturations of 40 on FiO2 of 1 and a PEEP of around 18 to 16 with a obesity of 150, 140 kilo with a severe disease, I was just thinking we must have been lost a good percentage of sick patients who came with multi-organ failure and with a very poor lungs and all. So my option was how much chances this guy has. But let me do our best. Don't give up. Let me do our best. We will just see what happened to this patient after this. Over to you, Sandeep.
Thanks. So after about 2 hours of rigorous oxygenating him, he was maintaining between 86 to 89. So because he was not maintaining, we have started to decide to prone him. But patient of about 140 to 160 kgs, proning him, that too with suspecting airway, though it has gone previously, certain things has also been taken care into, and how actually it was done, I'll be showing to you. So these are the sequence of ABGs of this patient. This was the initial AGB. When initial ABG before the intubation, he was having type 2 failure with hypoxemia. Even after intubation also, he has the same issues. So type 2 failure in both. But the moment we have proned him, that is about 6 hours after proning, there is a significant amount of improvement in the oxygenation of this patient. You can see about the PF ratios are about 125 and CO2 has started to come down. So a good amount of proning as ventilation, oxygenation and proning helped him to bring him out. So these are the initial laboratory parameters. His markers are very high, ferritin of 1100 and D-dimer about 1700 and IL-6 of about 1200. So because he was shifted from an outside hospital with these high inflammatory markers and fever spikes, we also got a procal with blood cultures. So as they were negative and high fever spikes with tachycardia, so we thought to give him a dose of immunomodulators because we have bevacizumab, which is a vascular endothelial growth factor, which affects the a dose was given that is about 0.5 mg per kg body weight, given over 90 minutes. Along with this immunomodulators, we started to give him a steroid of about 80 milligrams because he was roughly, we could not actually weigh him. He was about 140 to 150. We started him on 80 with a Clexane dose of 80 milligrams, roughly about 1 mg per kg body weight. So why actually is COVID important and obesity important, and why is there high propensity of cytokine storm in obese patient? So the main reason is because it is a major endocrine organs, though we call it as your adrenal or your other organs, but it is a pool of your cytokines, chemokines, and at the same time, adipose tissue has a good amount of, it helps in upregulation of ACE2 receptors, which is vital in COVID-19. So the moment you have more ACE receptors, more is the viral entry, more is the dissemination, so more is the severity, more chances of intubation, more is the mortality. So, and because you have a regular amount of chemokines, this is a chronic pro-inflammatory phages, which promotes more of inflammation. So these are the 3 to 4 which promote cytokine storm, at the same time severe illness in obese patients. So this image shows all the multifactorial involvement in obesity. The things what we commonly know is your diabetes, CAD, all things. But coming to the critical care point of view, as we spoke, one thing is your airway, ventilation problems, and your prone ventilation. And the immune system, which I spoke, because it's a chronic immunocompromised state with obesity, hypoventilation adding on, your lungs, because of reduced functional capacity or not to the full extent, reduced levels of testosterone, cortisol. All these are a game of events which helps the patient of obesity to bring down in their path of life. So add on top of COVID, it's almost double to triple. So on day 2, after about 16 hours of prone cycling, his PF ratios improved. So they were about more than 150. So because initially we only have a CT value of 15, we thought to get a CT PA for him because almost in the second stage of illness. And this is the initial ventilatory graphics of the patient, and he was requiring about 30, about 25 and 16 PEEP to volume generate about 380 ml. So, and in spite of that, he's maintaining at a
Sandeep, where
yes.
is our proning pattern? We wanted to show that proning. How did we did a proning in the obese?
Yes.
Okay, you wanted to go after this?
Yes, sir. After the CT, there is a thing, sir. So this is the initial CT. This is the CT what we got. So you can see more of the ventral segments which is getting involved. That is, you have a lot of dense consolidation which is getting involved on the ventral aspects of the lung. So almost in the ventral segments, totally it is the consolidation part.
So friends, actually during this period of the day 1, other than ventilation as a standard of care in the initial part of the second week, we were thinking about other therapies, including the remdesivir, which was initiated in this case. And then we were also thinking about giving a steroid dosing, which may somewhere between a milligram per kilogram or so, and a adequate dose of anticoagulation. So those 3 were started parallelly, and because of his rapid progression, that is within a day, they were saying the patient was on oxygen nasal prongs with a liter or 2, and rapidly gone down to almost to a 15 liters within a few hours, and then to NIV, and within a few hours they reached in our hospital. The saturations were around hardly around 40 on FiO2 of 1. So looking at all these things with a tachycardia of 140, 150, and with the markers very high, we thought maybe he's in a cytokine storm. So we were thinking about possibilities of a immunomodulators role with such a rapid and sicker deterioration. So the family and one of this patient, his brother-in-law of one of the senior internal medicine physician, who was also being a part of the discussion, available in the ICU, requesting with the family to do everything possible, and was also asking about the different options, including at that time extracorporeal membrane oxygenation, as we being a center who runs around a dozen and half of ECMOs with a transplant program going on. So in that period, we were also thinking about any immunomodulators at that time. So in immunomodulators, initially we thought about a tocilizumab, IL-6 inhibitor, but there were a lot of limitations of its availability, and the drug was not available freely to the institutions, and we have to write a proper performer letter to the government officials to get it from them, and it may take a day or two. That's what was the information given to us. So we, with a lot of discussions, we chosen the alternative immunomodulators at that time. Sandeep, can we actually switch over that slide and again share your slides?
No, sir, it got stuck, sir. The system is...
Switch off the laptop and switch on. So that's what has happened during this period. We were just contemplating how this patient will behave with us. And after proning, after a few hours, when I actually reviewed back the case, I was just seeing a saturation somewhere around 92, 93, with a FiO2 of almost 1, with a PEEP of 18 to 20. So that gave us some hope that, okay, let we continue our all efforts now without losing our hopes. Then overnight, there is a magical change happened. By next day, we could see his PF ratios has gone up to at least above 100 to reaching close to 150. And we have seen a drop in the requirement of his FiO2, and his tachycardia and the tachypnea, the tachycardia and all the other vitals organs-wise are getting stabilized. So this gave us a hope. And then we kept on actually proning and supining this case on the basis of every day 16 to 20 hours in prone, and around 4 to 6 hours to 8 hours in supine position. And in between, whenever he was in supine position, we try to discontinue his sedation, make him awake. We had a lot of terrible experiences with him because of his obesity. In spite of all padding, he had a lot of facial swellings, even the eyeballs and the periorbital swelling. So that added a further complexity. We had seen some variations in even pupillary asymmetry. Initially, we thought maybe this patient had a IC blade or something, but later on, probably this with a local compression, there was some pupillary asymmetry. And slowly, over the next 3 days to 4 days of time, after 4 to 5 cycles of proning without actually break, without any stopping, because the PF ratios were staggering between 150 in supine and maybe dropping below 100 in prone, 150 in supine prone, and dropping below 100 in supine. So we kept on proning for 5 days, and then we stabilized in supine, where his PF ratios remained to be more than 150. Actually, why we are bringing this case? See, we all of us seen many cases of COVID. Maybe we have treated around 25,000 to 30,000 COVID patients all around our organization with the 3 hospitals. And in ICU, maybe it will be close to 3,000-4,000 cases which we have dealt. And there are different layers of severity which we seen. Patients who are on HFNC getting better, patients who are on NIV getting better, patients who are requiring initial intubation getting better, patients who are requiring late intubation getting better, and some of them landing up to a very stiff and bad lungs and getting a secondary infection, getting into multi-organ failures and losing their life. So we have seen different spectrum of cases. And this case, which we actually encountered last week, was again a similar kind of a challenging situation with such a high morbidly obese, along with such a severe hypoxemia and refractory hypoxemia to even conventional ventilation. Initially, at the beginning, we had a very doubtful prediction of this patient's outcome because of these multifactorial challenges. But later on, within 6 days, we could actually extubate this patient out of the extubated to NIV, and within another 2 days, he was actually on to a NRBM, to a oxygen mask, to a nasal prongs, ambulated in the ICU, and today he is been shifted out to a ward, and we are planning to him to get discharged maybe in a couple of days. So why we brought this case? The reason why we brought this case is, see, these are the challenging situations, challenging cases, but even in these obese challenging situations, the basic critical care standard and the standard mechanical ventilation do help in them. It may not be all patients will be so lucky like him. Many may have a more complex course. Some of them may have a stuck with a very bad stiff lungs and very poorly compliant lungs and getting secondary infections and all. Luckily, this patient didn't had any secondary infected. All the cultures which we did on the 4th day when we had one spike of fever were sterile, and we could actually de-escalated the initial beta-lactam antibiotics which we started, and that's how actually this case came out. So we thought of bringing this case to all of you, saying that few of these mechanisms, the standard ARDS ventilation along with prone in a supervised and well-equipped manner with a good quality critical care do save lives. It may not be 100%, but yeah, good percentage of cases do well. We have actually, if you look at our even ventilated cases, intubated ventilated cases, our intubation is not early or not late. We always give a chance of NIV or HFNC in many of them. If we see the workup breathing is very bad, PF ratios remains to be very low, and the NIV need is going beyond a normal a couple of days of limit, and they using accessory muscles, paradoxical breathing or altered sensorium, any new organ involvement, we intubate them without waiting. And those who come in this situation in the ER, we don't wait for any second chance of giving any trial of NIV. We directly go and intubate them. And during this period of intubation, we have seen around 20-30% patients get extubated within the first week of time. The rest of the 70% patients need more time. Sometimes they go into a stage where they need a tracheostomy and then wean from there over a time and decannulate or go to rehab. And few of them, with the unfortunate reason, get into a futile eventuality. Over to you, Sandeep. Sandeep, can you complete the slides? Sandeep, are you there?
Sir, please unmute. Sandeep, sir. Unmute yourself.
Sandeep?
Yes, sir. It's done. Yeah.
So go to the last slides, wind it up.
So this is how we have actually prone the patient. So you can see actually what we do is in the single bed, we will be proning the patient with a sheet of bed sheets with about 3 to 5 patients, but 3 to 5 attenders. But you can see there are 2 different beds here, one bed here and one bed here, and support of the chest and abdomen is also available. So we have rolled from one bed over the other bed. And as we are rolling, you can see the airway circuit is being taken care by one of the patient. The rolling is by other sector of the patient, and foot end for standby patients by 3 attenders. So once we have proned him, we made sure that whatever support we are giving to the thorax and the lower pillow to the lower part of pelvis is also taken care just to promote ventilation. So once we have proned him, so this is how he was actually positioned, and we have also given, though it was not here, we have given knee supports. After that, we have given your elbow supports and simultaneously with the ankle supports, all the pressure points, and even the upper with the head ring has also been supported for the proper positioning.
Yes, Sandeep, the proning is generally done in the same bed because this patient was almost in full of that bed. So we had no space to actually prone this patient in the same bed. So we have to switch over to another bed from that bed, and we generally have a prone team. This proning team consists of respiratory therapist, our registrar, consultant, and in charge nurse, and the nurse who is taking care of the patient, and sometimes few housekeeping team. So all of them put together prone all our patients at around 4 o'clock, 4 to 5, we keep them as a proning time. And then again, the same team will again supine them at morning 10 o'clock. So this is a proning team who does this job every day. But because of this obesity, we took another 3-4 housekeeping and our colleagues helped to prone this patient. Over to you.
Yeah, thanks.
Is the slides got stuck again?
Yes, sir.
Okay, again, you can actually, can we take questions if we have any? So there was a question in which mode we ventilated this case. See, initially we started with volume control mode, regular assist control, volume control. And in that we targeted somewhere of 400, 420 ml of tidal volume in this patient, taking this ideal body weight, maybe somewhere around 90 kilos or 80 kilos. And then we started with the initial PEEP of 6 to 10, but nevertheless that never helped this patient, and this patient remained to be very hypoxic, saturating somewhere between 50 and so. Initially we started with IE ratio of 1:2, and we know there was no reactive airway. The peak airway pressures were not high, and this patient had never had any reactive airway issues, so we never thought of increasing E, because we know this patient had a severe ARDS, and that is the problem for both oxygenation and carbon dioxide washout. So we kept on actually titrating our PEEP to optimize the alveolar recruitment. And then we slowly decreased the E ratio to 1:1 to 1:1.5. And at that point of time, with a recruitment maneuver and PEEP optimization, this patient stabilizes somewhere in 80s. The initial respiratory rate for his CO2, we started with somewhere around 24. We try to settle between 24 to 30. So the ventilation is somewhere like this. So assist control, initially volume control ventilation with 6 ml of per kilogram of tidal volume, setting somewhere 420, with a plateau pressures targeting somewhere around 30, with a upgrading, uptitrating of the PEEP in him. There is another question of antifibrotic agent, ninitinab. See, this patient was in the initial second week of illness and looked like more of a alveolar opacities and dense consolidations. And we never thought this is the right time to start any antifibrotic agent. Ideally, we also don't start antifibrotic agent prophylactically in any of our patients. So we don't think any role of antifibrotic agent in the initial part of first or second week, where you have a frank ARDS with alveolar opacities more than a fibrosis in them. What the difference from others made him to come out of the ventilator? See, I think we initially thought of two important things which helped this patient. One is he was intubated straight on the admission time. Probably we have not given much of time because this patient was too sick for that. See, in other situations where this patient would have been saturating somewhere around 90 or above, I would have been given a trial of NIV. But because this patient was saturating below 80%, we never had a time to give him any NIV trial more than half an hour or so. So I think that one of the important thing which helped him, that we intubated in the first hour of his admission. The second thing which helped in him at that point is early proning. We proned him immediately on the second hour of his intubation with a good set of team members. So these two things, I think, as the important steps in this case management, which made a bigger difference in outcome of this case. The other way, what happens in many of the situations, these patients stuck for a long time in smaller centers, and then they get referred to us in the third week after they get failed NIV, almost into a stage where the lung is into a fibrotic stage, with a situation where you have a traction bronchiectasis, almost all the lung is badly, parenchyma is badly damaged, and they into a stage where they are getting into a kind of impending respiratory arrest, and then they come. At that time, when you intubate, it is more difficult to ventilate. Even at that time, you prone them, the proning response is not great in them. So I think these are the 3 or 4 important things which happened with this patient, and I'm not sure about how immunomodulator play a role. We have seen few patients who are the ideal choices. This patient who has a very high biomarkers and who also was in the first day of intubation, and probably procal was negative, and very early to get a second infection because we secured all the lines on the same day of his admission. So probably that maybe also played a role of immunomodulator. I'm not sure how much it helped, but yes, I can vouch that a high quality critical care, or what all of you are doing in appropriate time, is the difference which made this patient alive. The other question is tracheostomy or extubation, how you took a call after 5 days. Yeah, this was not on my when I was on round. I will be honest to you, many of my own colleagues, the senior consultant of my department, were not aligned with me in extubating this patient. They were saying, sir, this is too risky to extubate this patient. This guy looks very obese and tricky. The lung is too bad on a CT scan, and suppose if we extubate and this patient deteriorates, then we will have a hell of a problem in reintubating, and the chances will come on. So the decision how we made to actually extubate, not to go for a track, is the way he responded in the initial 5 days. The first day his PF ratios jumped somewhere above 150. Second day we could drop our FiO to below 60, and then persistently we could actually stop sedation, we could stop the relaxants, and then on supine we maintained for 2 days, and then we gave a spontaneous trial, that is we put into a pressure support with adequate PEEP and pressure support, and this patient was maintaining well. So we had a last day we had a discussion that we will give a pressure support and look at his CO2 retention, look at his oxygenation, and all were consistently above 150 to 200, and there was no CO2 retention, there was no tachypnea, there was no tachycardia, and his muscle power, neck holding was appropriate. And radiologically, yes, he was not favoring us. To be very honest to you, radiologically, his X-ray looked scary. I'm not sure whether Sundeep has those X-rays or not, but the X-rays were too scary to extubate this patient. But looking at his spontaneous breathing trial and the way he was holding his oxygenation, we all seen the radiological lag in COVID. So this is where experience comes into play. So we all know that CT scans and X-rays take their own time. So I looked at his oxygenation. I counseled the family and the clinician whose brother-in-law he was, who has a zero hope when he brought this patient to us. I told, see, look, we are taking a calculated risk of extubating this case to a NIV. See, mind you, my extubation was to NIV. That's called a progressive weaning. So we planned in that way, and we kept every airway trolley and difficult airway tray ready. If this patient do not tolerate, we will re-intubate. We took a longer time of weaning. We took 2 days of pressure support and controlled of on and off to see that in the night we rested, and the next day we again made him to pressure support, and we then extubated to NIV. So that's how we took a decision of extubating this patient, not to go for a tracheostomy. Sandeep, are your slides ready?
Just one moment, sir. You can take one more question.
I think there is another question that they had a situation where there was a patient whom actually they there were questions that why rocuronium was given. We had a choices between two, that as you all know, succinylcholine or rocuronium. We wanted a rapid sequence intubation, and the rapid sequence in rapid sequence intubation, we need a rapid acting drug, and rocuronium and succinylcholine both qualifies for that. We as a standard in our all intensive care unit either give rocuronium in when we actually are comfortable with the other gadgets of difficult airway. And in this situation where we had a LMA in place and intubating laryngoscope, intubating bronchoscope in place, so we gave a rocuronium so that we'll have a easy intubation in this case. We'll come to those questions once Sandeep completes his slides. Go ahead, Sandeep. Roll up the slides quickly to wind up.
I'm sorry for the delay. So almost after 3 cycles of prone ventilation, so after this is the prone ventilation, we have proned him for about 3 cycles. So 16 hours of each cycle. And after the 6th cycle, because persistently for the last 2 days, he was maintaining about 150 PF ratios, we have stopped proning him. But in spite of that, that level of plateau pressures are still at 30 because of his obesity wise. And these are the ABG after the 3rd cycle of proning. So you can see this is in the prone ventilation, only 35% of the requirement and a good amount of oxygenation. But the moment we supine him, he was hardly maintaining, he was requiring about 65 days. So there was a good amount of variation in prone ventilation. So, and usually
go back to the previous slide. So this is very routine and commonly seen phenomenon. Okay, whenever you're prone, you see a good amount of improvement in oxygenation. Your FPF ratios goes beyond 150 to 200, and the FiO2 requirement will come down. The moment you supine, in a couple of hours, again things will change. This has been a common phenomenon in most of our ARDS COVID patients, and more so in obese cases, which also happened in this case. Over to you, Sandeep.
Thanks. So this is a very large study which was done about 1,000 patients. So what they have observed is how to see whether your prone ventilation is actually useful or not. So in order to say that in 1,000 patients, one have done it, there is a significant amount of change in PF ratios in prone because of the 4 mechanisms, but there is no much change in the PCO2 levels or the compliance levels. So they have given certain guidelines to say whether he is a prone responder or not. First thing is, your PF ratio should increase about 20%. It's not just 20 value, it is about baseline about 20%. So, and this has to be done for a minimum of 3 cycles. 1-2 cycles are usually not much way to say it's as responder. Go for a minimum of 3 cycles, and there has to be a rise of at least 20% of the baseline value. And there is one more sector of non-responders. How to identify this patient is, one, your PF ratios won't improve. If they improve, they are less than 20% of the baseline. Second thing, the compliance or the plateau pressures, that is the plateau pressures will be at a higher level and the compliance will be at a lower level. And one more small hint is, your CTO2 levels will be at a border or a permissive hypercapnia range that says a severe form of disease and is not responding. So this CO2 is only for that particular study. Usually we'll be taking the 3 things: plateau, compliance, and PF ratios. So that's how you call a responder and a non-responder. So after about day 6, we have actually planned to extubate him. And so, so this is the protocol on about day 9, from between day 6 to day 9. He was holding on minimal amount of sedation, with the sedation halt in the morning. So he was conscious, obeying commands, and there's a significant amount of PF ratios. He was stable. So we thought to go up with extubation. So before extubation, what we thought is, as we keep extubation, we also thought of putting an NIV on a standby and subsequently putting on an NIV. The rationale for putting this is, one, your prophylactic NIV acts to decrease your respiratory failure, and your hypercapnic event, if it occurs, also will be taking care of your NIV. And this is supported by a study which was published in about 2016. So, so this was a CT scan which was done post after we have extubated him. You can compare the dorsal segments have come down significantly. The ventral segments have improved significantly. You can see that this has improved. So what radiologically, there is a good amount of resolution in the CT scan. He was hemodynamically stable. So we have extubated him on day 9. So after extubating him, we have started to put him on NIV, and there are about 5 to 6 different studies which suggest the role of NIV in obesity, and in patients with OSA, they help in weaning. At the same time, weaning is progressed. For about the entire night, we have put him on an NIV. The early next day morning, that is about day 10, we started to put him on, we have started to give him an NRBM trial, and he was holding much with an NRBM. GCS was very good. He was talking itself, and a minimal amount of on and off is desaturating. So in between, we connected for about 1 hour, and overnight we have connected back to NIV. On about day 13, because he was holding much, we started to give him oxygen support with Venturi, because there's a minimal amount of carbon dioxide which is getting retained. And the whole day was an NIV for about 24 hours. And we also started his rehabilitation right from the moment he was intubated with physiotherapy and limb physiotherapy. From day 13 to day 14, there was a drastic amount of decrease in the oxygen requirement. 15 liters has come to 10 to 5, and we could even mobilize him on chair, and he was doing a good amount of spirometry sitting in the chair with minimal amount of 1 to 2 liters of oxygen requirement. So about on day 14th, we have shifted him to step down, and in the step down right now, he is only requiring only 1 liter of oxygen support, and he is holding on. So I'll show the subsequent images.
Yeah, till that time I'll take questions. I think there were a question which says ki, the patient whom they intubated with a 6 ml per kilogram of tidal volume and respiratory rate of 30 and FiO2 of 1 after 4 hours, the CO2 has gone up to 167 and pH is dropped to 6.9. See, this is not very uncommon. In a very sick group of patients, we do see this kind of CO2 retention. The options here are initially you should see what is the cause for is so much of CO2 retention. Is it the gas exchange which we expect in a ARDS patient in this way? Is there any added bronchospasm? Is there any other things happening? What in our unit the practice is try to minimize as minimum as the circuits are. We take out all those the connectors, added on connectors which are not required, and we try to actually look at this tidal volume with whether we are predicted body weight related tidal volume or what, and then we try to reverse if there is any reversible cause. In spite of all that and taking out all the extra connectors, if you still see a very high CO2 and hypoxemia, the other two alternative options is one is maybe ECOR if you have only a CO2 problem, add on, and we have used in a couple of patients in the last week itself where we could actually troubleshoot the CO2. But if you have both hypoxemia and hypercapnia both being a problem, then we may need to consider them in spite of proning, bronchodilation and all the other maneuvers. If rate of 35 with, see in this sometimes IE ratio or prolonging E time may not help because these are not the airway reactive issues. There is no problem in exhalation. The problem is in gas exchange. So some of you students may in ARDS start prolonging the E because your CO2 is retaining. That may not help here. And sometimes the same 1:2 or 1:1.5 with good tidal volume and respiratory rate up to 35 and taking out all those extra connectors like catheter mounts, HME filters, all that may help for some time, and proning to improve the recruitment and alveolar recruitment and oxygenation. And then if not, then ECOR. ECOR is nothing but adding a circuit. We all know that carbon dioxide has higher dissolving coefficients, so it will be quickly be out of you with even small oxygenator. We use a regular the heart and lung machine oxygenator with a dialysis machine and take out them. I just will post the photographs of ECOR which we have done in our unit in the last week. In some of the situations where hypoxia is predominant, we also use nitric oxide, and we will see all of that. I will put images of all those practices which we have done in the last wave of pandemic. The ECMO it will be obviously the answer in situations where none of these respond. But yes, again, there is a lot of limitation with that. Complete the slides, Sandeep, the last few slides. Sandeep, can you hear me?
Yes, sir.
So last few slides, you take those last few slides.
Yeah, so this is almost the day 13 and day 14. He was chair mobilized. and he was requiring only about 1 to 2 liters, and he is doing a good amount of spirometry. He could raise 1 to 2 balls. So the major issues which we worried in this case is obesity and severe pneumonia, because they are add-on factors. Immunomodulators, and they particularly should be used very rationally. Difficult airway always in standby. Intubation, depending on 4 important criteria, take a call. Responders for minimum 3 seconds and rise in PF ratios, followed with an NIV immediately after extubation, and rehabilitation or your physiotherapy exercise should start right from the moment. That is, once you are done with your proning session, it has to be started immediately. The thing is, simultaneously, the nutrition is also the other thing which has to be taken care in this patient, and he was given as the same protocol what we follow regularly. So this was he was about to shift out to the step down. So he was very happy with all the particular, because the sisters are the one actually took a good care of him. He thanked all of them. So this is how he has come out.
So some of the times we will be lucky like this, and patients and families thanking us, and the gratitude shown to us is enormous. He wrote almost a book of letters to all of us. And believe me, it is not just a critical care specialist there. Okay, this is a team. The team consists of housekeeping team who has actually helped us in proning, a nursing department, a respiratory therapist, and all other specialties who helped us in doing this wonderful job of teamwork. So with this, we will take some other questions. So which is better, early intubation or late intubation? But most of the patients will have a low PF ratio. See, not early, not late, appropriate time of intubation. Whenever you feel the patient is needs an intubation, please intubate. There is no early, there is no late for intubation. As in this patient, we never waited for even an hour. We intubated her because this patient had all indication. Okay. The second part of the question is all patients of COVID are low PF. We don't look at PF. The earlier concept of PF less than 150 for intubation may not hold good for COVID patients, because this is a different pathophysiology and different kind of all set of disease. Many of patients who are between less than 150 to 100, or some of them even less than 100, did wonder by HFNC and NIV with self-proning, and they all of them recovered well. So whenever you use HFNC or any non-invasive modalities, make sure that you are monitoring the patient. If your patient PF ratios are getting better, your oxygen requirement is getting reduced, and the workup breathing is not worsened, the tachypnea, tachycardia, other vital changes are dynamically not worsening and they are improving, and you can wean in between them for a meal, for a break, then probably you are in the track of recovering. So these patients can be given a trial of further NIV. But if the patients worsen on them, probably these are the candidates who should get intubated then and there only. If you drag these patients beyond a certain limit, then probably the outcome obviously will be worse. The important other things is whenever you put these patients on NIV, they drag a lot of tidal volume. Sometimes you see they're dragging 900 ml of tidal volume. This amount of high tidal volume can induce a PCL. The patient induced spontaneously injuries to his lungs because of that high inspiratory pressure which they drag. So this has been, other than the common standard things which you know, the PCL has been under a debate that if a patient is dragging a lot of tidal volume, that is beyond 9 ml per kilogram on an NIV, that's a bad prognostic marker that you may land up in a situation where this patient will harm himself by those tidal volumes. The other things, you know, there are very different scales which you can use, a rock scale for HFNC, modified rocks, or other scales for NIV modes. And most importantly, during this COVID, we have seen clinical judgment, bedside clinical judgment. That is your oxygen requirement, your respiratory rate, your accessory muscles, workup breathing. These became the more important parameters to decide whether this patient can be continued on NIV and need an invasive ventilation and lung rest. So I think that's the point, not early, not late. So does these, any other things? So some drugs are given according to the total body weight, some given to the, see, it depends on the drugs. Like see, we are debating about low molecular heparin. If you look at the low molecular heparin, even in enoxaparin, dalteparin, many of them are ideal body weight related. So you cannot take them as a many of them are total body weight related, low molecular heparin, not ideal body weight related. This is all related to your drug accumulation and drug dosing. So you have to choose the drug according to whether it is been dosed according to the total body weight or ideal body weight. How many prone sessions do you need if the PF ratios are see? We don't take the PF ratios when the patient is in prone. See, what we do is if a patient maintains a PF ratio of more than 150 after 4 to 6 hours of supining, we stop proning. That's the criteria. Not the PF ratios in supine, because we have seen PF ratios of more than 200 in prone, and then when we supine, it drops below 50. So that kind of situations is very commonly seen. So we only look at the PF ratios when the patient is supine and has been 4 hours or 6 hours has been lapsed, and the PF ratio still maintained more than 150. What happened in this particular case? So I think these are the different parts of the questions. Other questions are there here. Sir, does the recruitment maneuver are really helpful in COVID ARDS lungs? See, recruitment has been gone through a lot of controversy with no significant actually amount of literature supporting its benefits. Yes, it may benefit in a subset of population, or definitely it may improve oxygenation, but the sustainability of oxygenation with the recruitment has been always questioned. Did recruitment help in all our COVID patients? My answer will be no. But did recruitment help in few of our patients? Yes, it does. One of the example of exactly this case, I personally recruited this case with around 60 pressures with 40 PEEP for almost 40 seconds, and I kept a PEEP of around 26 for almost half an hour of time to optimize his PEEP, and this patient's lung opened up. Probably maybe there's obesity related, the whole lung atelectasis or the whole lung got into collapse state where I could actually recruit more of the alveolus in them, alveolus which collapsed and opened up. But not all patients get recruited, and not all patients get better with just recruitment. And recruitment will have both. See, recruitment maneuver may overdistend you, or recruitment maneuver may recruit your alveoli. So you have to know your lung, look at your radiology, look at your lung compliances, and see whether your recruitment maneuver is helping your oxygenation or not. If it is helping, then probably you can continue recruitment. Otherwise, no. The simplest and easiest and most physiological recruitment is proning. Please do prone. So that itself will help. See, I have recruited this patient only once during the initial phase where we are not able to saturate him above 60. But after that, the proning did all the magic. I hardly had to do any recruitment. See, a similar amount of management in lean patient didn't help. No, see, it's not about obesity. It's not about lean or low body weight or normal body weight. It is about what I was talking about is we may have a different challenges to face. We have lost young patients, and we have made around 95 years old survive. So this one kind of statement, not fit to all, not all obese patients will die, not all lean patients will survive. What we wanted to send a message by this case is that you keep on your efforts of high quality critical care on. There are many factors of this survival or death. See, we do believe that many patients, in spite of our high quality critical care with ideal management, we lost many. And we have seen this kind of a very low possibility of survival cases did made it to the desk. So it is not about just a body weight in all situations. And nutrition, there were some questions related to nutrition. We fed them enterally. The moment we tubed, in the day one, first hour, we started feeding, and we have given around a 1 kilocalorie per probably around 100 kilocalories per hour. That's around 80 to 100 ml. We generally give 1 kilocalorie per ml dilution. So we started feeding from day one, and the feeding continued till patient get extubated, and we kept a Riles tube for a day or two because of risk of reintubation on NIV with open Riles tube to outside. But enteral, no parenteral at all in this case. Enteral was the nutrition, and we do feed these patients in prone position. If that is the questions, we do feed these patients in prone position. And generally, we don't use bolsters, which we used in this case between the chest and the hip. We generally just we use a air nimbus bed and prone them with pillows. But in this case, because of a lot of truncal obesity, and the trunk was almost like a 80 kilos, so we thought of we may need to use bolsters in this case, but with good care of the team, there were no pressures in them. Any other questions? So, sir, immediately after intubation, very difficult to ventilate. Also, saturation gets long time to improve. So this is common, sir, in COVID ARDS. Often we feel doubt whether the yes. Very interesting. And we had the same thing. Believe me, after the tube is in place, we connected the vein circuit initially to see whether the tube is in place, and there was a bilateral chest rise. We had a ETCO2 connected, and we have seen the tube in place, but it took almost half an hour of time. The saturations were staggering between 36, 38, 40. Believe me, if I would have been not had a ETCO2 in place, I will always extubate and reintubate this patient in those situations. But very scary situation. Bilateral good air entry, ETCO2 in place. A anesthetist who intubated this case under a complete vision. We trusted that, and we kept the tube in, and this was just ventilated. Yes, very common, and you have to keep your patients on. Don't just pull the tube out just because the saturations are not getting better. You just look at bilateral air entry, chest rise, ETCO2 if it plays, and don't pull out the tube. That will further deteriorate your patient, and you may get a arrest in this situation. We were all ready with adrenaline, atropine. Believe me, we were all prepared for a impending cardiorespiratory crash. There is no denial for that. I think these are the few queries. No, I won't say early intubation is better. No, I think many of us initially thought and got some information across the globe that early intubation will make a better. No early, no late. Now across the globe, if a patient is having saturating well above 90 and respiratory rate is below 30 and is comfortable with even on prone position, I will just wait, will not rush for intubation. But yes, if his workup breathing is worsening, he is desaturating rapidly, and his vital signs changing over more than 20%, clinically, I will take a call on intubating this patient, not waiting and dragging this patient. But not all patient with VF ratios less than 150 in COVID, I will intubate. I will give always a trial of NIV HFNC. And remember, the common contraindications for NIV HFNC, if you have an altered mentation, if you have a severe acidosis, if you have a hemodynamic instability, if you have a facial deformity, if you have a contraindications for NIV, intubate this patient directly, no waiting. I think, how will you calculate transpulmonary pressure by CVP? Okay. See, ideally speaking, the plateau pressures of 30, which we generally consider as a limit for ARDS safe ventilation or ARDS ventilation, may not be accurate because of variation in transpulmonary pressures in them. So ideally, we should have a transpulmonary pressure measurement by either esophageal manometry or some other equipment, which now we have some ventilators which have. And in those situations, if you know the transpulmonary pressure, then you can go up to the higher plateau pressures to see that the exact plateau which is applied directly to the lung may need higher. So in this case, we didn't measure the transpulmonary airway pressure, but yes, initially we ventilated crossing the plateau of 30. I think we initially ventilated with a plateau of around 36 to 38. Then later on, we could come down once the patient is prone to below 30. So see, FiO2 and NIV. See, somewhere clinically we may take a judgment between 0.7 to 0.8. We generally don't wait patients to go to FiO2 of 100 for more than 72 hours. If my patient's requirement of FiO2 is more than 0.8 and the patient is tachypneic more than 35, I think these are the patients who will require an intubation in a quick time. And if I'm dragging them more, I'm probably harming them more. But it is not just FiO2, it is not just only PF ratios, but I look at their workup breathing, their respiratory rate, and their overall the vitals. If they are tachypneic, they are tachycardic, they are diaphoretic, their ABG is worsening, they are acidotic, and they are getting drowsy, they are getting exhausted, their workup breathing is getting affected, then I will intubate. Suppose I have a patient with 0.9 FiO2 and respiratory rate of 20, and he is not using accessory muscle, I will just give more time and repeat ABC, see even whether he is improving. It will not just mean FiO2, but yes, anything more than 0.9 or 0.8, I will be more careful in them. Somebody with 0.6, I will be more comfortable on an IV. I think with this, we come to an end of questions, and I think there are a few more questions, but I think with the limitation of time, I thank Sundeep in bringing this case. I thank all the participants who are here along with us in this case discussion and for the questions. I hope you all got some glimpse of it. We know there is no one ideal way of doing anything. You may learn many algorithms, but when it comes to bedside, when you face a case, it is completely a different ball game. So the clinical experience will have no match to any guidelines, any protocols, and you need to probably customize your approach, individualize that approach whenever, wherever it is needed. And with this, I thank all of you and conclude the session. Thank you.